Thank you, Arushi, and welcome everybody, and thank you for joining us for the MyIBD Learning webinar. Tonight's webinar is focused on a very important topic, LGBTQ care, or not LGBTQ care, IBD care for the LGBTQIA patient. We're going to hear from our guest speaker on the ways in which inflammatory bowel disease uniquely impacts LGBTQIA plus folks and identify ways to improve knowledge and care for this historically underserved group. My name is Morgan Pullyblank, and I'm just thrilled to be facilitating tonight's program. The Crohn's and Colitis Foundation provides the latest information on IBD to our patients and caregivers through our MyIBD learning education programs. And we encourage you to explore the website to learn more about our virtual and in-person programs and read more about the presenters. Just a couple of housekeeping notes before we begin. Everybody is on mute for this webinar. This presentation will be recorded and accessible after the completion of tonight's program. And if you do have questions for the speaker, and please do have questions for the speaker, so feel free to type them in the Q&A box, which is at the bottom menu bar. We'll have a dedicated Q&A session at the end of the presentation, but please feel free to stick them in the Q&A box at any time, and we'll make sure that we get to them. Now I'd like to introduce you to our speaker, Dr. Justin Field, who is an assistant professor of medicine in gastroenterology at the University of California, San Francisco. He's originally from Wilmington, Delaware, and completed medical school at Jefferson Medical College and residency at Temple University Hospital, both in Philadelphia. He completed his training in gastroenterology at Mount Sinai in New York City and did additional fellowship training in inflammatory bowel disease at UCSF. He has a particular interest in identifying and addressing the unique needs of LGBTQIA plus people with IBD, and his research focuses on this as well as anal cancer screening and prevention. Dr. Field lives in San Francisco with his husband, Mo, and their dog, Napoleon. And without further ado, I'd like to introduce Dr. Field.
Thank you so much, Morgan and Arushi. It's my absolute pleasure to be here. I'm thrilled to talk to you today. Let me go ahead and share my screen. All right. Are my slides up?
Yes, we can see them.
Yeah. Perfect. All right, so today I will be talking about IBD care for the LGBTQIA plus patient. As Morgan mentioned, I have an interest in advancing healthcare for LGBTQ folks living with IBD. As I was going through medical training, through residency, fellowship on the East Coast, I noticed there was a major lack of focus on the needs of LGBTQ folks. Sexuality was barely mentioned or discussed, let alone marginalized sexual orientations and gender identities. And this was in major city centers like Philadelphia and Manhattan. So then when I went to go and try to find research to help guide taking care of LGBTQ people with IBD, there was so little. And that really inspired me to help improve care and the care experience for my own community. So I'm going to talk about what I've found in the research and what's out there. This will not be completely exhaustive, and I'm really excited for the Q&A. I'm excited to have a discussion about what are the things that that you all feel that are important as well that I might have missed. So I'm going to use a lot of different terminology today, including queer as an inclusive word for diverse gender identities and sexual orientations, in terms like MSM, which means men who have sex with men, or WSW, which means women who have sex with women. These are terms that focus on sexual practices and don't assume people's identities, as well as LGBTQ and LGBTQIA+. So I am an assistant clinical professor of medicine at UCSF, and I have no disclosures. These are the program disclosures. All right, and so The LGBTQIA plus population is a growing population. And in fact, there's been about an 82% increase in the proportion of people identifying as LGBT or something other than heterosexual between 2012 and 2021. Um, you, among people identifying as LGBT, Gen Z is actually the group that's had the biggest growth, those born between 1997 and 2012, with nearly a quarter of Gen Z identifying as LGBTQ. We know that this is not a new phenomenon. LGBTQ people have always been there. It's that stigma and barriers to self-identifying have improved over time. That being said, LGBTQIA people face discrimination in accessing healthcare. And so this data comes from a survey from 2018 from the Center for American Progress. And in this survey, 8% of lesbian, gay, and bisexual respondents reported that a clinician actually refused to see them, whereas 29% of transgender respondents reported that a clinician refused to see them. 6% of LG and B people reported that a clinician refused to give them health care, as opposed to 12% of transgender people. 7% of LGBT people reported that in the healthcare setting, somebody refused to recognize their family, including children and partners. And then 9% of LGBT people reported experiencing harsh or abusive language. And then 21% of transgender people reported experiencing harsh or abusive language. And 23% of transgender people reported being misgendered or having the use of the wrong name. And so this has impacts on the ability to access healthcare. And so 8% in the same survey of LGBT respondents avoided or delayed care, including 14% of those who had experienced discrimination in the prior year. And 22% of transgender respondents avoided or delayed care. And as we know, IBD is a condition that requires a lot of care and a lot of follow-up and trust with the healthcare provider. And so this is extremely important and extremely upsetting and important to address. This table stratifies for that question of among transgender respondents by ethnicity. And so as you can see, there are ethnicity variations within the trans community, and that highlights the fact that intersectionality is important. Having multiple stigmatized or minoritized identities can increase the rates of mistreatment. So today, let's talk about what the implications are and the opportunities are for LGBTQ people with IBD. So I'll talk about making the diagnosis, the disease impact, cancer risks, and the research needs of our community. So first, I'll talk about making the diagnosis. So one question that comes up is, are LGBTQ patients at higher risk for IBD? So what we know is that transgender patients have a higher prevalence of type 1 diabetes, lupus, and Graves' disease, which are autoimmune diseases, but there are similar rates of inflammatory bowel disease. Lesbian, gay, and bisexual patients, we still don't have clear data to answer that question. There was a large study analyzing the correlation between ICD-10 codes, which are billing codes for Crohn's disease, and a code called high-risk homosexual behavior, which is very vague and problematic, and found a correlation between this diagnosis code and Crohn's disease incidence. The problem with using that code is that we don't really know what people meant by high-risk homosexual behavior. Was it just their perception of somebody's behavior? Are they talking about specific sexual activity? And so that gets washed out, and we don't really know what that means. So the methodological flaws limit our ability to interpret that data. Another thing that's important to know is that patients can sometimes be misdiagnosed with IBD. There's the appearance of an infectious proctitis on colonoscopy can actually mimic ulcerative proctitis and Crohn's disease. And there may be a significant number of patients who are misdiagnosed with IBD for that reason. And that can lead to inappropriate treatment, delayed diagnosis, and increased transmission to other partners. And so infectious proctitis is likely increasing overall as STIs in general are increasing in the US. And the table on the right shows the increased rates between 2012 and 2021 of gonorrhea specifically. And there are some studies that have looked into this a bit further. This is data from 2 studies that looked at infectious proctitis misdiagnosed as IBD. And so in these case series, the appearance on colonoscopy and biopsies was nearly identical. So much so that the patient received a diagnosis of infectious or of IBD. And they went on to be treated with mesalamine, steroids, which we know can be problematic with infections, and advanced therapies, including biologics. And the diagnosis was delayed by months and even years. And so the ultimate cause was chlamydia, Neisseria gonorrhea, syphilis, and lymphogranuloma venereum, which is a form of chlamydia. So this proposes a call to action. So there's an urgent need for providers to ask patients about their sexual history. Providers should inquire about gender identity and prior surgeries involving genital anatomy, because these can affect similar areas as Crohn's disease and ulcerative colitis. Providers should inquire about recent STI testing and offer testing, if possible, of any body part involved in patient sexual practices like the throat, rectum, penis, or vagina, or really any appropriate area. And then those who have oroanal sex or anal intercourse should be offered immunization for hepatitis A and B and HPV, which can be sexually transmitted. And we'll go into that a little bit more detail later. So now I'll talk about the specific impact of IBD on LGBTQIA+ individuals. So we know that IBD negatively can impact sexual health based on prior studies and surveys. And this data, some of the bigger studies found that there's a 97% prevalence of women reporting sexual dysfunction. And this uses a scale called the Female Sexual Function Index, whereas 30 to 40% of men with IBD reported erectile dysfunction, and that uses something called the International Index of Erectile Function. The reason I mention these specific scales is because we don't really know how the scales apply to those in the LGBTQ community, those who are men who have sex with men, women who have sex with women. They ask questions that may not be completely relevant to MSM or WSW folks, and so they weren't validated in that group. So we don't really know if those numbers are exactly the same. And so we need to have more studies that have validated testing and validated scales in the LGBTQ community. There's a really great study that was a survey and included a lot of patient quotes regarding the experience of LGBT folks who are living with IBD. And so one patient said, "There's always a section saying sex and relationships. And it says, oh, it doesn't affect your sexual life. You can still continue to have sex with your partner." And you're like, "Well, I can't because, I've got this pouch." Another patient says, "I wasn't 100% top or bottom before, and therefore it's not a complete change for me. But I think the main change is mentally, how you think about sex and how you approach it. I used to quite regularly have sex with men who are more dominant in their character and physicality, whereas now I obviously can't do that." So this kind of gets to one topic that is often brought up, and that's anal intercourse after J-pouch surgery. And anal intercourse is not exclusive to any specific group. Cisgender, transgender, straight, gay, many people have anal intercourse. And after J-pouch surgery, we don't have any published data regarding the prevalence or safety. So patients are often looking to discussion websites, word of mouth, and there can be conflicting and inaccurate information on those websites. Anecdotally, patients may avoid or defer needed colectomy due to the fear of the impact on their sex life for people for whom the rectum is an important part of their healthy sexual activity. So receptive anal sex is possible after J-pouch surgery. It's not risk-free, but is possible. And one issue is that there's a narrow anastomosis between the pouch and the rectal cuff that can become narrow and be a major barrier. So one approach is complete avoidance for 6 months post-op while healing. Let the suture line heal with slow introduction of graduated diameter anal dilators over a 6-month period. Stopping if there's pain, avoiding rough sex, and assuming positions with increased control, such as the receptive partner on top. Another issue that may come up is there can be exposed staples at the anastomosis. If this is present, it can cause discomfort or injury to the inserting partner. And so one thing I recommend is discussing with a colorectal surgeon. That's one thing that we do at UCSF for pouchoscopy, and they can remove the exposed portion of staple. And things that we don't know, we need more research on, is the risk of pouchitis, what is the impact on continence, which is important with a pouch due to having more liquid stools, and susceptibility to STIs. So now I want to talk about gender-affirming care in IBD. So gender-affirming care is the social, psychological, behavioral, and medical interventions which are designed to support and affirm an individual's gender identity. This can intersect with IBD care in several ways. So one is when a patient goes to the clinic, goes to the hospital, are people using their affirmed name and pronouns? And then another question that can come up is, are there potential interactions with gender-affirming hormones and IBD? And then how to prepare for gender-affirming surgery with active IBD. So gender-affirming hormones in IBD, these often include estrogen for feminizing effects and testosterone for masculinizing effects. So in terms of estrogen and IBD, there's no data to date specifically in transgender individuals with IBD using estrogen. But we do have some data that in other groups that has informed this discussion. And in postmenopausal women on hormone replacement therapy, there's a slightly increased risk of Crohn's disease. But in another study, it was actually estrogen was protective against disease activity. There's a question about an association between hormone replacement therapy and blood clots. But these studies are not necessarily generalizable to transgender people. So we need specific data in that area. And that's one area that I, as well as folks from University of Michigan, Mayo Clinic, Oregon Health and Sciences University, and Vanderbilt are looking into now. And so testosterone and IBD, there's no known association between testosterone use and the risk of developing IBD. And there's conflicting data on testosterone use in blood clots, but we will hopefully have more information to guide that discussion coming soon. So the bottom line here is there's no strong data establishing a risk of gender-affirming hormones in IBD, but we do need more data. But patients should be affirmed in their choice to start hormones, and really this can be individualized. So if a patient is starting hormones, they talk in talking to their gastroenterologist or provider, they may have a little bit more close monitoring with fecal calprotectin or an endoscopy in the period after. And in terms of gender-affirming surgery in IBD, there's no specific studies to date, but potential concerns would be that if there's pelvic inflammation, that can prevent or complicate surgery. So the treatment goals may be slightly different for a transgender person who's thinking about undergoing surgery. There are case reports of the development of Crohn's or colitis of the neovagina, and that depends on the technique used, if a loop of bowel is used to create the neovagina. And then surgical healing, as with any surgery, can be impaired if there's a history of recent steroid use. And so interactions with the healthcare system, as alluded to in the results of that survey, they can be very difficult, especially for transgender and non-binary and gender non-conforming people. There can be misgendering, a lack of recognition of partners, and assumptions of sexual orientation, sexual activity, and gender identity without really having a conversation about it. These are some more patient quotes. It's a traumatic thing you're going through, but you don't feel as a gay couple or as a gay individual that you have that same freedom to express yourself in that way. Once your visitors are gone, you're left to the other patients in that space. You can't escape it. So the last thing you want to do is create an atmosphere or feel intimidated or make anyone else feel uncomfortable. We were not able to say goodbye to each other. We were not able to have a kiss and a cuddle because we were on a ward. We learned a long time ago that people, although very accepting, they can become quite different if you start showing physical affection. And so these are experiences that are unique to LGBT people that have IBD that other folks may not have to deal with. I want to take a moment to talk about the impact of IBD on queer women. So this is an area that's specifically understudied, and so much attention has historically been focused on cis gay men, and we're really lacking in this area, but this is what's known. So queer women have fertility concerns just like other women, and doctors and providers should ask patients about their desire for pregnancy and not make assumptions. Cervical cancer screening is important in this group, although rates may be lower among queer women of screening uptake. And we know that in IBD, especially with immunomodulator use, mercaptopurine, azathioprine, rates of cervical cancer are higher. There are higher rates of tobacco use among lesbian and bisexual women, and this is associated with worsening of Crohn's disease. Vulvovaginal symptoms are common and may be related to the Crohn's or colitis itself, or the effect of medications. And there's increased rates of bacterial vaginosis among lesbian and bisexual women. And then finally, there's increased rates of polycystic ovarian syndrome among queer women that can also impact fertility. I'll talk a little bit about cancer risk in IBD, and specifically IBD and anal cancer. So the risk of anal squamous cell cancer is elevated in IBD. The risk in ulcerative colitis is about 10.2 per 100,000 person years, which is about tenfold of the average population. The risk in Crohn's is 7.7 per 100,000, but in those with perianal Crohn's, the risk is about 20 per 100,000 person years. There is a worse prognosis for anal squamous cell cancer in IBD patients, and people with IBD tend to present younger than those without. The good news is that there is a precursor lesion that can be intervened upon and treated to prevent anal cancer. And this is called HSIL, or a high-grade squamous intraepithelial lesion. And as you can see on the picture, it's very subtle and can be somewhat difficult to detect with just colonoscopy. So HPV is causative in 90% of cervical and anal cancers. So this is the human papillomavirus. It causes up to 70% of oropharyngeal cancers and the majority of penile, vulvar, and vaginal cancers. HPV is the most common sexually transmitted infection, and actually about 80% of the world's population will be exposed or infected with HPV at some point in their life. There's over 100 subtypes of HPV. Subtypes 16 and 18 these are the important ones that are associated with most cancers, whereas subtypes 6 and 11 are associated with genital warts. But HPV is vaccine preventable. So that we have a vaccine, it's called Gardasil, and it's recommended for all adults, regardless of gender, up to age 26. And after age 26, historically it was not recommended, but the CDC recently changed their recommendation so that people up to age 45, it's recommended to receive the Gardasil vaccine if it's recommended through a shared decision-making process. And so if somebody has not been exposed to 18 or 16, those are the higher risk subtypes over their life, it may still be worth getting the Gardasil, even if they're well past their sexual debut or the first time they had sex. The diagram below shows how HPV works. So it infects the cells in the anal canal and the cervix. And in many people, it will just get cleared by the immune system. And in some people, it will persist. So we think in Crohn's and colitis that either inflammation or possibly the effect of medication allows the HPV to just persist in the cells and stay. And over many years, it can progress to precancer and then even further progress to cancer. So besides IBD, these are the other known risk factors for anal cancer. And the biggest one is HIV, and that's associated with far and away the highest risk of anal cancer. Other risk factors are being a man who has sex with men. Transgender women have higher rates of anal squamous cell cancer. Those with a history of vulvar cancer or precancer. Those on long-term immunosuppression, prior cervical cancer or HSIL, having a history of multiple sexual partners, and smoking. So which patients with IBD should be screened? And so it's recommended to consider screening for patients with perianal involvement and fistulas, those who have had long-standing immunosuppression, and we still don't have an exact sort of number on what that means, but people who have been on biologics or for 10, 20 years, or maybe have been on multiple rounds of prednisone. And then anal cancer does not significantly increase in prevalence until older age. So really not starting screening until after age 35. And then people who have IBD can also have other risk factors. So it's really important to be aware of the other reasons to be screened for anal cancer. And so history of HIV, MSM, men who have sex with men above age 45, transgender women above age 45, having a history of vulvar or cervical cancer and precancer, having known high-risk HPV, having a history of multiple sexual partners, receptive anal intercourse, and solid organ transplant recipients. So how do we screen? The first step is with a digital anorectal exam. So that's an exam with the finger that really screens for cancer itself, which usually is you can feel with the finger. It won't detect things like the precancerous lesion like HSIL. So for that, we have anal cytology, which is also known as an anal pap. This takes a swab of surface cells from the anal canal and can detect the precancerous lesion. It's not the best test. It has a pretty bad sensitivity and specificity, but it is well tolerated and quick and can catch a lot of precancer. The gold standard test is called high-resolution anoscopy, and this is analogous to cervical colposcopy, and it uses vinegar and iodine to highlight abnormal areas for biopsy and treatment. It's about 15 to 30 minutes long. It can be done in the office, in the endoscopy suite, or the OR. It doesn't typically require sedation. And it allows for both detection and the treatment of precancer. Not a lot of providers know how to do high-resolution anoscopy, so the screening depends on what is the availability of people in your area who know how to do the high-resolution anoscopy. So in areas where there is not availability of HRA or anoscopy, then screening involves asking about symptoms like has there been any bleeding, discharge, itching, pain that's new, visual inspection, and a digital exam. And then in areas where high-resolution anoscopy is available, then screening involves all of the above, plus cytology or a pap smear. And then based on that, if the cytology shows results such as a high-grade lesion, a low-grade lesion or LCIL, ascus, which is abnormal cells of undetermined significance, or high-risk HPV, then patients should be referred for a high-resolution anoscopy. So to summarize, patients with IBD, especially those with perianal involvement and possibly long-standing biologic use and frequent prednisone use, are at increased risk for anal cancer. Anal cancer is most often caused by HPV infection. And the Gardasil vaccine is preventative against cancer-causing HPV. And screening can begin with an anal cytology, and any abnormal results should be followed up with a high-resolution anoscopy procedure. So finally, I'm going to talk about what are the research needs in this space. And I alluded to a lot of gaps in knowledge, and really a lot of the research that has been done has been done in the past few years, and there's a lot of research that's ongoing, which is really exciting. So the historical barriers to research is one of the biggest ones is that sexual and gender minority information, so sexual orientation, gender identity, that's not consistently collected in when patients go to see their doctor. It's not asked, it's not documented, it's not listed as part of the demographics in the electronic health record in a lot of cases, which if things aren't counted, just like the census, then they can't be included. So if people aren't counted, then they can't be included in research. Another issue in that is that historically research has used gender incorrectly, as classifying that as gender assigned at birth. So if somebody joins a clinical trial, they may only be asked their gender assigned at birth, or sort of be required to report that, instead of their gender identity, which might more accurately reflect their lived experience and their other risk factors. And then finally, stigma affects participants and researchers' willingness to engage in sexual and gender minority research. Not wanting to be identified or outed, or a researcher might not want really that to be their career focus for various reasons. So breaking down stigma is really important. So how can we improve research in sexual and gender minorities? So one huge one is just encouraging and facilitating the documentation of sexual and gender minority information in the electronic medical record. That really helps do studies and include the diverse expression of gender and sexual orientation in studies. Increasing community engagement, making people aware that there is a need for more research, and using explicitly inclusive language of sexual and gender minority individuals in studies. And then what's extremely paramount is ensuring the security and privacy of patient data. This chart shows example responses to that might be included in a study asking about sexual identity, sex assigned at birth, gender identity, transgender identity, sexual behavior. Right. So in summary, sexual and gender minority individuals are at similar risk for IBD as non-sexual and gender minority individuals. People who practice receptive anal intercourse are at increased risk for STIs, which can mimic IBD. Gender-affirming hormones appear safe in IBD, and more data is needed to clearly define the risk. And anal cancer is elevated in people with inflammatory bowel disease, especially perianal Crohn's disease, and screening should be considered and account for other risk factors that may prompt screening as well. There's a significant need for more collection of sexual and gender minority information, open discussion of sexual practices with all patients, and more research into the needs of LGBTQ individuals with IBD. One way that I hope to help address knowledge gaps and care gaps in my own community is through the UCSF Rainbow IBD Clinic, which is coming this month. It will provide culturally sensitive care for LGBTQ people with IBD, incorporating the latest research. There will be coordination and collaboration with colorectal surgery and transgender health services. And I will be offering high-resolution anoscopy for anal cancer screening, which I've gotten additional training in. And I'll be joining another clinic nationally, the Pride IBD Clinic at the Mayo Clinic, run by Victor Shadid, and also an upcoming one at UCLA. If anybody's interested, feel free to email. These are support resources for patients and caregivers. Thank you so much. That's my presentation. I'm really excited to take questions and talk more.
Dr. Field, thank you so much for this presentation. I think the statistics that you showed at the beginning, just in terms of the barriers to care, really drive home how important it is that we're having these kinds of the Pride clinics and the research, and just being really explicit about caring for the LGBTQIA plus community. So we have a couple of questions already. I'm just going to start reading them. And anybody who has any other questions, please just stick it in that Q&A box. So the first one is anal sex in the setting of a perianal ceton for fistula dangerous?
Yeah, so that's a great question. And really it should not be, with sufficient lubrication. And if the fistula itself is not inflamed, there's no reason that the ins and outs of anal sex would be an issue with a ceton. And cetons are generally soft and shouldn't cause any discomfort or injury to the inserting partner. So that's a great question. And really, as with anything, it's sort of take things slow, use lots of lubrication, and but no reason that it shouldn't be safe.
Next question is, if my partner had HPV 20 years ago, am I at risk for contracting it? And what should I do to protect myself?
Yeah, great question. And so HPV we call it an STI, we call it a sexually transmitted infection, but it's not something that you really need to kind of go about, trying to avoid, because most people are exposed to HPV so early on, and it's so prevalent that when a partner has HPV, we don't really recommend taking any extra steps to avoid it, because most likely you've been exposed, even if not with that partner, with another partner in your life. And so I would say, if you haven't gotten the Gardasil vaccine, I would there's really little downside to getting Gardasil if you happen to not have been exposed to certain subtypes like 16 or 18. Getting Gardasil could help you prevent getting that subtype in the future. So that would be the biggest way to protect yourself.
Thank you. Next question is anal cancer risk increased even after perianal disease is healed?
Yeah, we don't know. There's not research in that area. That's something that I'm looking into. But as with any cancer risk related to inflammation, the duration of inflammation matters, and having inflammation under control is always going to be important. So controlling inflammation will mitigate or decrease the risk overall. But we don't know if it to what impact having a history of perianal disease in the past increases the risk, even if it's controlled now.
Right. Can taking testosterone or HRT affect how well your Crohn's medication works or cause the need for a dose change?
Yeah, that is something that we're looking into. There's a multi-center study going on now looking at the rates of IBD flares and incidence of IBD after starting testosterone and estrogen. It does not seem like, from the data that we have so far, that there is much of an impact, if any. But that there more data and more information on that will be coming soon.
Right. Next one is somebody who says he is a gay man with UC in his mid-20s and has been through 3 different GI doctors in 3 years of being diagnosed. First with Prostatitis, then advanced UC. None of my doctors have asked me about my sexuality or desired sexual practices. What tips do you have for patients who want to broach the topic of sex and sexuality with their doctors?
Yeah. That's, I'm sorry that you've gone through that, and sadly, it's not you're not alone. And I think trust is important, and you have to feel safe. I don't know where you live particularly, but um, you know, it's not unreasonable to want to protect yourself and want to you feel safe with your doctor. But I think in many areas of the country, you can feel comfortable, even if your doctor is not really that comfortable with the conversation. They will, saying, "Hey, can we talk about my sexual health?" And seeing where that leads. That could be one way of starting the conversation. If your healthcare system has a questionnaire asking about sexual practices or your sexual orientation, that might be a good way to just sort of get it in there, um, and and see if that sparks a conversation. But always feeling empowered as much as you're comfortable, and feel safe doing so. Just letting your doctor know. In 2024, we would hope that healthcare providers are okay with and accepting. And of course, that's not always the case. But I would hope that you're just having that conversation and bringing it up, even though it's really should be the doctor's responsibility to ask. Um, if you feel like you're able to ask or bring it up yourself, then that might be the best way.
Thank you. And the next question is wondering if you have an area of IBD specialty along with the LGBTQIA plus. Like, do you primarily work with Crohn's disease or ulcerative colitis?
Yeah, so I see all patients with IBD and Crohn's and ulcerative colitis. And my specific research areas of interest are in the unique needs of LGBTQ individuals, and also helping define the risk of anal cancer a little bit better. So we kind of know who with IBD is at higher risk, because as we know, all patients with IBD are not created equal. Some have inflammation in one area that may, and some don't. So how is that important? And so that's my research area, but I see all patients with IBD, including Crohn's disease and ulcerative colitis.
Thanks. Next question is, what are your thoughts on doxy prep for STI prevention? Can that cause resistance or flares?
Yeah, I think the I think we'll have more information about resistance in the future, but based the data so far has not shown resistance to be an issue. I think having a chlamydia or gonorrhea infection would probably be more detrimental than any potential risk of a flare um, or resistance in the future. Um, I think if you're someone that has always flared after antibiotics, then that might be something to avoid, and maybe in those cases, thinking about other ways to avoid those STIs. But generally, having a, a rectal an infectious proctitis would probably be more detrimental than the risks of doxypep.
Right. And then the next question is, any suggestions for manufacturers conducting IBD treatment trials to make them more inclusive for LGBTQIA plus individuals? And I'm going to add a second part of that, which is any tips for LGBTQ patients who want to participate in research. So let's talk about both the manufacturer side and the patient side when it comes to participating in clinical trials and research.
Yeah, I don't. I haven't personally participated in clinical trials or helped run a clinical trial, but I have talked to some folks at different pharmaceutical companies, and just really emphasize that you're asking about gender identifiers, asking about sexual orientation is super important. There was one clinical trial for a newer medication that asked about sexual health, and I asked them if they had asked about sexual orientation or gender identity, and they hadn't, and they were really grateful that I brought it up. And so yeah, I think everyone has their blind spots, and so anytime there's a patient advocacy opportunity, anytime that there's opportunity for patient input, if you have that chance, let them know that that's important. And I think it's more just what you don't know, and so spreading awareness will help.
Thank you. And the next question is, my 28-year-old son has had UC for about 14 years and been on immunosuppressants of one type or another. He had Gardasil at age 11 or 12 before sexually active. Is it recommended that he get another dose?
It's not currently recommended to get another dose if he had a 3-dose series. So the newest recommendation is that to have a 3-dose series. The initial Gardasil vaccine only had, I believe, 4 strains included, which were the most cancer-causing strains, but the newer version has 9 different strains of Gardasil. So depending on when he got Gardasil, it may be worth repeating the series.
Is there a way to ask these kinds of questions of your provider and also ensure they don't list it on the portal so other providers don't see the notes?
Yeah. I think just mentioning that this is a sensitive thing that you would rather not be documented, I think that there's really no reason why that wish should not be respected. And I mean, you can ask ahead of time, hey, if we have a discussion about something that I would prefer not to be documented, would that be okay with you? Just to get a sense of if they're going to agree to that. But there's, I think patient wishes should always be respected, especially with documentation of sensitive things that could potentially be detrimental. I mean, we have patient privacy acts, and but stigmatized communities have good reason to feel guarded, and I think it's completely reasonable to ask of that of your provider.
Thanks. So next question is, does Crohn's or colitis affect the healing time after gender-affirming surgeries?
That's a great question. We don't know that in the context of gender-affirming surgery specifically, but in terms of if healing after abdominal surgeries for people on biologics is the same, it's not recommended to keep people on their regular schedule of biologics like Remicade before undergoing surgery, because there's been a large study that's found that the healing is the same, and the worst thing that you can do is tip somebody in a flare by holding their medication. And so with gender affirming surgery, it would be presumed that if there's no active pelvic inflammation, that healing should be the same. And if and medications such as infliximab or Remicade or other biologics should not impact the risk of or impact healing. Prednisone does impact healing, so avoiding being on prednisone for the weeks or months before the procedure or the surgery.
Thanks. And then we have 2 is anal sex safe questions, so I'm going to bundle them. One is after repeat anal surgeries in a tight sphincter, and the other one is with anal stenosis.
Yeah, so the main limitations may be comfort and the inserting partner's ability to insert. In terms of safety, there's really no data that says that it's unsafe. We in the for anal stenosis, dilators are frequently used, and so using dilators, working with your colorectal surgeon to come up with a regimen to help open things up. I think if there's active proctitis, there may be more tissue sensitivity. So, avoiding in times of a lot of inflammation, avoiding anal sex, and just that's why being able to talk about these things with a gastroenterologist or colorectal surgeon is so important, because they can sort of take it step by step and walk you through it, and come up with a plan to, if you're not where you want to be, to get where you want to be. And that's your right, and everyone's right as a human being to have a healthy sex life. But great questions.
Right, well, thank you so much. That was the last question. There was so much great information shared throughout this evening. Big thanks to Dr. Justin Field for sharing your knowledge with our audience today and answering all of these questions. And before we end today, I want to remind everyone to please fill out the evaluation survey that you'll get as soon as we end the webinar. We really appreciate that feedback, and it will help us to plan future programming. Thank you so much to everybody for joining us. And before we say goodnight, we would like to invite you to check out your local chapter's upcoming events on the Foundation website or their social media page. The next MyIBD Learning is going to be on August 6th. And that will be about IBD accommodations in school. So thank you so much, and have a wonderful evening.